So the previous speaker has actually finished talking a lot on my topic. So I'm going to finish really fast on this one. Uh, main uh, surgeries which come for shoulder rehabilitation are again previously been described is rotator cuff tear, which comes majorly unstable surgeries shoulders, and shoulder replacement, that's arthroplasties, are not done very commonly, but you would get few if your hospital or the place where you practice has a person who does shoulder surgeries. uh, how do we proceed with rehab? Again, the previous speaker has described some in detail. It depends on the what kind of surgery are you doing, how much chronic is the problem for the patient, what kind of repair has been done for the patient, how much soft tissue do we have, how much bony involvement has happened, and what is the person going to use that shoulder for. So the rehab will be different for, say, for an 80-year-old versus somebody who wants to lead an active life or want to return back to competitive or recreational sports. The number one point here is most important. The first thing which the patient wants from you is that the ROM has to be restored. The rest of it, some of them are compliant, some of them are not compliant. They may come to you, they may not come to you for strengthening, for functional movements. But if you can do it, if the person remains in touch with you and continues to finish the rehab program. Again, the previous speaker has spoken that most of the shoulder rehab programs are not like the hip and the knee rehab programs, which finish very early. They tend to go on for weeks and months. Not everybody remains compliant with the rehab program. And the point is to start with supported positions and then to go to unsupported positions. So you need to know how to transition from step to step. Patient needs to be educated. Again, it was previously pointed out, what are the steps to protect the recovery, to help to protect the repair, to help it heal, to prevent further problems, and how to return back to sport or work. So this is what is the rehab program in a nutshell. So the first 6 weeks are generally given for passive ROMs. The second 6 weeks are given for active ROMs. Once the ROM is reasonably good, that is when you start moving to a strengthening program. There are some overlaps depending upon the surgery. Again, the previous speaker has spoken on some of the overlaps. I will also be touching on it briefly. And then it's after 20 weeks that you consider a return to sport. So 20 weeks is roughly 5 to 6 months. So that is the kind of timelines that you're looking at. Most of the rehab programs are broadly divided into 3 phases. Like I mentioned in the previous slide, the first program for the first few weeks is generally focusing on passive ROMs. Sling is being used for the first 6 weeks. The sling should be removed only during the time of the exercise program. Otherwise, the recommendation is to use the sling as much as possible. In the initial phase, focus more on distal movements, the elbow movements, if there is no biceps repair being done, and the wrist and hand movements. Phase 2 is when you start moving from passive to active. So initially it begins with active assisted, and then you go to a full active movement. And in the passive phase, the ROM that you aim for is about 90 degrees of flexion. And if you're going for external rotation, then 20 to 30, not more than that. In the second phase is when you go for more ROM. And the third phase, you plan for strengthening and return to full ADL. So this is how you actually break down the rehab program. These are the number of slings, so it depends mainly on the surgeon preference, but most of the times actually it should depend on the type of surgery. If you look at what the recommendations are for the slings in the second line. So it is either in the neutral position or in the slightly internally rotated but abducted position that the sling recommendations are. Now you have ROMs, restricted kind of slings also, where you can dial the ROM as it is shown in the last figure, but these are the kind of slings which are used. And this is an exercise program. Again, I'm not going to go into real details of it. You can just take a photo, and there are n number of papers which describe. I have put in the papers also at the end of it, at the end of the slide. So this is what the program is in nutshell. So first 6 weeks for passive, for the next 6 weeks for active, and then for strengthening, and then for return back to sports. And there are specific drills for each and every kind of this. So this is one paper. There are multiple such papers which are coming up in recent times. So if you can look at what I've highlighted, there are studies which say that there is no real difference between a supervised exercise program versus what the patient does himself. So supervised exercise programs are now generally offered mainly to high performance individuals, and the rest of it you can actually give a home program and still get the same kind of results. So if you have a practice where you don't have recourse to good skilled physical therapists, say you're doing a pain practice and you have to do exercise program on your own, then this kind of thing is fine. So you had seen in the previous this. So this is basically the first two slides are for passive ROMs in external rotation and in flexion. And then you can transition from passive ROM into active ROM. You start with a short lever position of the arm and then gradually go to a long lever position of the arm. And then you use banded exercise, bands for strengthening external rotators and for flexors of this. Once you finish everything, you can go into a completely unsupported position. The last exercise can be done with weights in the hand as well for further strengthening. So if you follow this protocol and just just stick to the timeline restrictions, this can be done just about. You can just tell the patient, give instructions, you do one demonstration program, and the patients can still do it at home. The precautions for particular kind of surgeries was again covered by the previous speaker, so I don't want to. If you have a larger tear or you have a more repair, then obviously as it was discussed, the rehab program should start a little late. So you start ROM exercises a little late. Wait for a couple of weeks, 2-3 weeks. It doesn't make any difference. The rates of loss of ROM is not as much as it is as we imagine it is. The ROMs do come back. You can start with isometric strengthening little early in rotator cuff surgeries if it's not a massive kind of tear and a massive kind of repair is done. Just be careful of external rotation. Most of the ROM should be done in the scapular plane. That is where there is least stress on the repair. And scapular mechanics need to be corrected. This I have seen happening many times. In spite of going to a therapist, this is not paid attention to. So the patient just learns, especially with a long chronic they keep learning how to shrug and do movements, and that goes on to the post-operative phase as well. That needs to be corrected. You need to have a biofeedback technique either in front of the mirror or auditory cueing or any this that you have, that this has to be stopped. All the ROM should be done without shrugging. And if you look at what is a good outcome for surgery, the papers say it's 65%. It varies from center to center and but this is what large studies say. Supine exercises are supposed to be better as compared to standing exercises. So you can actually start supine exercises. Even in the prone lying position, you can do exercises. They eliminate gravity and put less kind of stress on the repair. For instability surgeries, again, the ROM should be started little late. Wait for a couple of weeks. Don't worry about it. Again, you will not have too much of post-operative stiffness. It will come back. External rotation should be careful. Once you progress to the strengthening phase, strengthening has to be done in slightly provocated positions because you need that strengthening to happen. And when can the person come back to activity? When you get almost 80% of strength and almost full ROM, and the apprehension test is negative. Around 15% of the patients will still have a recurrence after all of this as well. And for shoulder arthroplasties, again, if the shoulder arthroplasty is done for an indication like osteoarthritis or osteonecrosis, the outcomes are going to be better. If you do it for a rheumatoid arthritis or a trauma, the outcomes are going to be slightly less as compared to the others. So don't be worried about it. Tell your patient. And again, the previous speaker told you that if the rotator cuff is fine, then do an arthroplasty, otherwise a reverse one. Avoid, like for the hip, the same way there are some positions that to be avoided. So extension, adduction, and internal rotation has to be avoided. Otherwise, the prosthesis might subluxate. And return to sport time in this kind of this is the longest. So it may take almost a year by the time the person returns to. Again, for some of this, so cryo, how much cryo should be done? This again, we underutilize cryo. Cryo should be used very much. So this is the standard advice for cryo. The studies say that it should be done at least 6 times a day for about 15 to 30 minutes at a time for 2 weeks to begin with, and then you can reduce the amount of cryo. But early, lots of cryo should be done. Reduction of pain and reduction of swelling is very, very important for you to progress. So how do you progress from stage 1 to stage 2? Again, ROM improves and the pain is less. So if you have the ROM criteria which you are meeting and the pain is less, then you can progress from step 1 to step 2. You need not then wait exactly for 6 weeks. You might progress a little early if the surgeon is fine with it. And then you go on from strengthening, from ROM stage to strengthening stage, and from strengthening to return to sport, depending upon 2 things. One is that the strength is almost 80% of the opposite arm. You can use a dynamometer and find out. Or the external rotation to internal rotation ratio is about 70%. So the external rotation is at least 70% of internal rotation. You can progress to the next area. When do I use occupational therapist? I use occupational therapist only and only if I need to readapt the person. So nothing is going to help. The overheads are not going to come. Then you can use readaptation of working environment. Some people like to use isokinetic. It varies from surgeon to surgeon. We don't use isokinetic unless the surgeon tells us that I want you to use isokinetic. Isokinetics are used only in the ROM phase. It cannot be used other time. So there are some outcome scales that we use. There are a number of outcome scales. I've listed all of them. The one which we use commonly is this constant scale. It can be resized to 1 page, and it basically has items like pain, ADL, strength, and you can score it on that, and anything which is above 65 is considered as a very good outcome. So this is how. So I wanted to put this slide to show you what happens. So if you do a whole load of shoulder surgeries, about 80% of them will go back to work, 20% will not. That is considered as a good outcome. And this is the amount of time that it will take. For pain to go completely, it takes more than a year. The patient will have something. Please don't get worried about it. The same thing with the ROM recoveries and the strength recoveries also take months and months. It's not like knee and hip where it happens much faster. Shoulders happen much slower. Don't be stressed about it. This is a very common question that is asked: when can I drive? So if that is why these scores are helpful. If you have a constant score which is on the higher side, above 60 and all, the patient is fine to drive. Most patients can drive by when the sling is off. So around 6 weeks is the time that majority of the patients can drive. Some younger patients can drive faster. If you have somebody who has an automatic vehicle, they can drive faster as compared to somebody who can't. So return to sport, again, this is done in very specific places only. Return to sport should be done once I showed you the criteria. The second is that there are return to sport drills. So you go from drill to drill and this from stage to stage, depending upon what is the kind of sport that the person wants to go back to, what is the performance that you're looking at, and what are the criteria for the sport. So with overhead sports or with sports which require throwing action, they have to be done much later and with much stronger exercise program as compared to somebody who say wants to go for table tennis or something which is much easier to do. So you have to test the performance. You have to see that the person meets each and every criteria. Please read these 2 papers in great detail. They have at least 10 tables on return to sport criteria. It's just too long. That's why I did not put all of them. But this is what the basics are. What complications come to me for management? Stiffness comes to me very common for management. About 10% of the patients can have stiffness. If they don't work with traditional, this is what I do. I generally do a nerve block. You can do 3 nerve blocks at this place. You can do a suprascapular nerve block, you can do an axillary nerve block, and you can do a lateral pectoral nerve block. All 3 are superficial, excellently and easily done under ultrasound if you have, or with a nerve stimulator. If you have a re-tear, generally an MRI is absolutely necessary. These people will go back to the orthopedic surgeon, so they will get an MRI done. If it's an anterior tear, they can make or an anterior superior kind of tear. Generally, surgeries, it depends on whether the patient wants to do. If the patient doesn't want to do surgery, then rehab. Posterior tears are generally rehab itself. Again, here the rehab program depends that you have to delay the ROM. So if you have an anterior tear, you have to delay flexion, and if you have a posterior tear, you have to delay this. But the rehab program remains the same. You still go through the same phases again. For partial tears, you can do PRP injections. There are papers which are coming up on the effect of PRP injections in partial tears after surgery, and the results are reasonable. You can try it. If you have late pain present, you can do cooled RF. Again, the same 3 nerves can be targeted with a cooled RF machine. It's again easy to do if you have cooled RF. Or pulsed RF is also okay in these kind of patients. So this is what I was trying to tell you. So if you have you please read again this paper, which again shows this in very great detail as to what happens when you have a rotator cuff surgery patient who comes back to you after a few months and tends to have this problem which is persistent. So if you look at what I do with rotator cuff, these are the things that I do. I have to take care of the outcome. So I have to see that my outcome remains reasonable. So I use these outcome scales which I showed you. I have to manage select complications of patients who come to me either referred by the orthopedic surgeon or comes to me directly from some other source, and talking to the patient and making them understand the role of what you are trying to achieve with them is what is most important for us to do in this. So thank you to Dr. Selvan, Kerala chapter, and thank you, audience. So I try to finish on time and
Thank you, Dr. Nitin, for the excellent presentation, and another thank you for keeping the time. Thank you.
The previous 2 speakers, you may remain here, sir. Dr. Nitin. I invite Dr. Paul Anthony and Dr. Ramya Matthew to come to the stage and be ready for some questions. Total for 5 minutes only. At 10:15, the session has to be closed. Please move a little to the center. Any questions from the audience? Yes, Dr. George Joseph wants to ask.
My question, or rather a comment, is mainly for Dr. Paul Anthony. See, I have been seeing rotator cuff injuries, especially supraspinatus, confirmed by MRI or ultrasound, complete tear, and suggested surgery from elsewhere, but either the patient is not willing or he cannot or she cannot afford because of the economic considerations. Then I have been treating them conservatively with the mobilization, strengthening exercise and all, and they have a fantastic improvement in function, and their weakness almost completely disappears in 3-4 months. And is it necessary that all patients with a supraspinatus injury, complete injury, should undergo surgery? What is your opinion? What is your experience with the conservative management?
See, one of the important factors is age. See, any muscle, if it torn, it is going to retract and atrophy. So, if younger age group, if I say, we say 50s or younger, we should go for repair, because the later you cannot do it. But if in older age, I have patients with extensive massive rotator cuff like supraspinatus, infraspinatus, and with occasional pain. I just do physiotherapy and leave them. But younger patients, we need to repair it because they are going to face problems in the future. So that time you cannot repair it. Then we need to do some like superior capsular repair, all these things. That is not going to, now we have come out with lower trapezius transfer to support supraspinatus. So that and all will not give that 100% good result as supraspinatus there. That is why we want to repair it in younger age group.
Okay. Okay, I agree with you. And this is true. I also agree this is true for younger generation, younger people. But mainly what I am talking about is elderly patients above 50 or so.
No, we will
mainly
not.
housewives.
Functionally good, and
Yes.
we need to for what all it's for the pain or for the function they want. Then only we decide. If there's pain, we'll go for repair. If after exhausted all the physiotherapy mode, because this is like if an exercise rotated of repair, it will give you all the surgery. So I don't think that immobilization, if they are already good movement, I will not go for a rotated of repair. In older age group, there are so many other factors like what the function they want and how is the pain, depending on that. Depending on that, we will decide on the because I have when the beginner, I can say maybe 10 years back when I started, I did a scopy for he has almost full movements. I saw the MRI, extensive rotator cuff muscle is retracted. I thought I can repair it. Then I couldn't repair it. Then I told the patient I couldn't repair. I'm not charging you. That time I was in private, and patient is happy. That day I decided no, I will not decide on the repair just by MRI, and we need to see the functional function of the patient, what all things he want to do, that is important, and pain.
Okay, thank you, Dr.
That's it.
Any other question? Dr. Ramya, you are fitting that orthosis at
Right from the early phases, sir. Right from the early phases. Acute phases. We get patients from
how many
post-ICU.
days after the stroke?
Almost, because that becomes a mandatory thing when the patient start high sitting or when the patient is coming out of the standing frame, because then only the patient starts walking with the gait supports, no, sir. So at that time we keep it mandatory to be in the sling support during the walking or gait training trial. Till then, the pillow support positioning and the patient is bedridden, it's not getting that mandatory. Thank you, sir.
It is very important that the stroke victims have to be referred to the physiatrist as early as possible. Positioning of the affected hemiplegic shoulder is very important for avoiding shoulder pain and for better recovery from many of the complications that can occur in future in all hemiplegics. This is to be made compulsory, or it may be understood by all treating physicians as well as surgeons as well as any other persons who are handling the stroke victims. This is very important. The patient's complications after hemiplegia, especially to the shoulder, can be avoided to a great extent by keeping the arm in abduction and external rotation. I think this is one important take-home message which you want to tell.
Anybody else? Dr. Paul, one comment about shoulder wheel. You mentioned about shoulder wheel. We physiatrists never prescribe shoulder wheel immediate post-operative period. But some over-enthusiastic physiotherapists may be doing it. Not we.
No, I am not against shoulder wheel. My thing is whether that is, it's a big thing, and even I seen in most of the physiotherapy centers, it is lying like that, not using, because so many other techniques has come, simple things. And I think it is a little costly also. And some physiotherapists I asked, you know how to use it? Because in my earlier days, I am from CMC. So they used to do IS in every time somebody is working on that. Nowadays it's like, the exercise cycling at home. it's using for putting some clothes or something. It is same thing happening for the shoulder wheel. So because a lot of other type of simple things. See, now previous physiotherapy is we used to tell the patient to come to physiotherapy unit. Now, actually only, it's like a supervision only most of the time happen, especially rotator cuff repair. You need almost 1 year rehabilitation. It's not extensive rotator, it may take 1 year. So you need only supervision. So you need to teach the patients what all things you should do at home. They will come to you once in a week or like that, twice a week. So we need to teach the patient, these are the things you should do, and patient will come and you will assess, and some correction needed. That is the way now it's going on, now the way it's developing. Because I have exposed to the other places, so outside before when I was in India, it's like immediately after this thing, daily physiotherapy. No. Actually, that is what is happening. Patient stimulus is gone. The patient should know that I also need to do something. Or after surgery, now the doctor's responsibility to mobilize the shoulder. Or the physiatrist's responsibility to mobilize my shoulder. My responsibility is over, I paid the money. No. Patient involvement is very important in shoulder mobilization, especially after rotator cuff repair.
Thank you. Now, shall we wind up this session? Okay, thank you.
May I now request Dr. Surendran K. to kindly present a memento to Dr. Ramya Matthew. Now, I request Dr. T.K. Vasudevan to kindly present a memento to Dr. Paul P. Anthony. I request Dr. M. Jayasri to kindly present a memento to Dr. Nitin A. Menon.
May I now request Dr. Anitha Sadish from GH Trivandrum to present mementos to our chairperson as a token of gratitude. First to Dr. Surendran. Second to Dr. T.K. Vasudevan. Third to Dr. Jayasri.